group of us, several researchers in Chicago who were working on colorectal cancer, became interested in particularly what you're seeing here, which is this is the slide showing incidence for males and females of colorectal cancer. Hard to get the pointer there, but basically it was at that time that we were seeing the highest difference in terms of incidence of colorectal cancer between African Americans and non-Hispanic whites, and for that matter, the rest of the racial groups. So we're really wondering what the cause of that was. And certainly access to care and access to colorectal cancer screening does have an important effect, and that should be taken into account. But also, I think it's important to point out what I'm showing you right here, which is that while screening for colorectal cancer is lower, was lower, and still lower in the African American community, other groups in the U.S., such as Asians and Hispanics, do also have, actually they have even a lower rate of colorectal cancer screening, yet their incidence of colorectal cancer is not as high as in African Americans. So in order to really try to help answer some of the questions on these disparities, we put together Chicago Colorectal Cancer Consortium, which basically was meant to be a comprehensive study on colorectal cancer with particular emphasis in addressing disparities. So the goals were really to establish a large, robust, and well-characterized multi-ethnic database and biological repository of colorectal cancers with a high proportion of African Americans, and to study molecular and genetic features of colorectal cancer and their interaction with nutritional, behavioral, and toxic exposures. And by design, we really wanted to focus in an area, particular area in the city that would really be multi-ethnic, and would also be one of the areas that would have the lower socioeconomic status, and that's here in the south side and the west side of Chicago, and that's where we recruited. In the 5 hospitals we were recruiting patients. So they would be a multi-ethnic group of individuals, but they would share a lot of the same environmental factors. So we thought that that would be more important if we're trying to explain disparities looking at this specific area. And so we saw several things. One of them, for instance, and that was quite significant, was the difference in location of the colon cancer, seeing that in African Americans, there was a significantly higher proportion of proximal tumors versus non-Hispanic whites, 34%. And one would think that this higher proportion of right-sided tumors in African Americans would result in a higher percentage of microsatellite unstable tumors, because those have been more commonly associated with that. But in fact, we saw the exact same frequency of microsatellite instability for both African Americans and non-Hispanic whites. And basically what this is showing us is that the excess of colorectal cancers on the right side is not really microsatellite unstable tumors, but actually what they are is microsatellite stable tumors. Other significant differences were, for instance, the presence of lymphocytic infiltrate, which African American colorectal cancer tumors did have a higher percentage, significantly higher, 29% versus 12%, and also a more advanced stages for African Americans and in comparison to non-Hispanic whites, which we've been known for a while. There were no differences in the mutations in the MAP kinase pathway genes. Another aspect that we wanted to learn from was the age of onset. And here what I'm showing is the, on top we have African Americans, here non-Hispanic whites. And what we did is we compared the individuals from 2000 to 2002 versus individuals recruited from 2011 to 2012. And what we saw in both cases for both African Americans and non-Hispanic whites was that decrease, that significant decrease in the median age of diagnosis, 61 for African Americans to 62 for non-Hispanic whites. And those ages were definitely lower than the SEER data reported for those years, 65 for African Americans, 70 for non-Hispanic whites. So to the point that we saw that 22% of individuals, African American individuals with colorectal cancer, were presenting below, at an age before age 50, and that was 15% of all non-Hispanic whites that were presenting with colorectal cancer. We decided to expand and look at the data from Cook County, which includes the entire city of Chicago plus several suburbs. So definitely the socioeconomics kind of shift quite a bit, and not focusing on that lower socioeconomic area. And even though the percentages are lower than what we saw in that particular group, the trend was exactly the same, which is like a significant change in the age of onset, lower than 55 for African Americans, from 16.7 in between 96 and 2000 to 19.9 to 2006, 2010. Same thing with the lower numbers for non-Hispanic whites. And this is really what later has been reported with SEER data with, again, is this big contrast between the incidence of colorectal cancer individuals older than 50 for both men and women. Yet this increase that started in the late 90s of incidence in the younger than 50 years of age. And that's resulted in basically an average 1.8 annual, 1.8% increase, annual increase from 2006 to 2015 of colorectal cancer incidence among individuals that are younger than 55. So really a very fast development that we've seen, that we actually witnessed live as it was happening with the Chicago Colorectal Cancer Consortium. Another interesting fact is that slide shown here, which is among this group of younger than 50 individuals with colorectal cancer, while the trend has been going up much in a very consistent way for non-Hispanic whites, for African Americans has gone up just slightly. And basically what's happening here is that these are converging. So among these younger individuals, we seem to have similar incidence of colorectal cancer for both Blacks and non-Hispanic whites. Other some associated factors with this younger age of onset: distal location, for instance. The individuals with colorectal cancer in the distal area of the colon were younger at diagnosis, and that was really another significant finding here. So. And another important fact, and even though it did not reach any statistical significance, there was a trend for all those distal colorectal cancers, these younger distal colorectal cancers, to be more commonly obese and more commonly associated with tobacco and alcohol consumption. So more probably related to the environmental factors. So in summary, African Americans and non-Hispanic whites are being diagnosed at younger ages with colorectal cancer, as we've also been seeing with the last reports. And the excess of colorectal cancer in African Americans predominantly consists of more proximal microsatellite stable tumors, commonly presenting lymphocytic infiltrate and less often associated with toxic exposures or higher BMI. So younger African Americans, and for that matter, whites, also have more distal colorectal cancers than older ones. So really, with that information in mind, we really wanted to understand biological differences in colorectal cancer among African Americans through the analysis of somatic mutational, copy number variation, and methylation profiles, and compare features among younger versus older individuals. So we started looking at the somatic mutational spectrum. So we proceeded with exome sequencing analysis of 45 colorectal cancers from African Americans. We excluded microsatellite and stable tumors. And basically, we called somatic variants through Strelka, and we identified the cancer drivers through MUT-seq analysis. Of those tumors, 43 were stable, 2 had polymerase E mutations, and they were hypermutated, so we excluded those from the cohort. And we saw that there were 32 recurrent mutated genes that were identified, each of them having at least 3 non-silent mutations. And 7 of those out of those 32 are the well-established colorectal driver genes, as you see here, APC, P53, KRAS, MAT4, and 2 of them were novel genes that are reasonable drivers. One of them is PREX1, and the other one BCL9L, which is part of the Wnt signaling pathway. So we wanted to see the specific mutation rates of some of those driver genes, and we compared this cohort of African-American tumors with 186 non-hypermutated colorectal cancers in non-Hispanic whites from the TCGA. And what we saw here is that while frequencies of P53 and KRAS mutations were similar in both groups, this group of African-American tumors and the group from the TCGA of non-Hispanic whites, what we saw was a clear difference in terms of APC mutations, where in this group, there were 63% of the tumors that had APC mutations versus 80% of the non-Hispanic whites from the TCGA. So important difference in terms of APC mutation burden. So we try to understand better what could associate with this particular with the particular group of patients with tumors with no APC mutations, and we'll look at different features. And one that stood out right away, that those individuals that were APC mutation negative here in comparison to the APC mutation positive were younger, much younger at diagnosis than the APC mutation positive. They also trended to have more previous cancers, but basically what was statistically significant was that association of these APC mutation negative tumors with younger age of onset. We then looked at the TCGA and see if that would hold true with a group of 219 non-Hispanic whites that were not hypermutated. So of those, there were 181 that had APC mutations versus 38 that were APC mutation negative. And as you can see here, same held true here with this cohort from the TCGA, which is basically that APC mutation negative were associated with younger age of onset than the individuals that had positive APC mutation. So we're really intrigued, and we looked a little bit more and compared the mutation burden of APC mutation positive tumors versus negative. And here we also saw a significant difference where APC mutation positive had more mutations, 170 versus the 107 of the APC mutation negative. So again, APC mutation negative, less mutational burden. Then we wanted to see if we could understand better the mutational mechanisms, and we did several things. One of them is we compared the frequencies of mutant triplets in exome sequencing data. And what we saw here, looking at all the tumors, both APC mutation positive, which is the top row, versus the APC mutation negative. So in both cases, we saw predominance of C to T mutations in the CpG dinucleotide, really reflecting a mutational process dominated by deamination of methylated cytosines. As really, this is the signature that you expect for microsatellite stable colorectal cancers. So in this case, we did not see any differences on this mutational pattern here between APC mutation positive versus negative. Where we saw actually differences was here when we looked at copy number variation. So what we really looked is that chromosome arm gains and losses were substantially lower in the APC mutation negative tumors, which are the ones on top, versus the APC mutation positive tumors. So in this case, we did see a significant difference, but again, on the same lines that we're seeing less mutations, less mutation burden, and those are more chromosomal stable tumors in general. So we're left with this subgroup of APC mutation negative tumors that are associated with a younger age of onset, that have a very low mutation burden in comparison to the other ones, and we really don't have much of an explanation of what's driving these cancers in this group. So an obvious candidate from the mechanistic standpoint is, well, were there epigenetic changes that would actually drive this carcinogenic process here, considering the low number of mutations. So what we did is we proceeded with mutational epigenetic or methylation arrays, and we compared a group of APC mutation positive and a group of APC mutation negative that you can see at the bottom. And as you can see, they really clustered very nicely. We did see close to 6,000 differentially methylated regions. And basically what we saw is that in general, in APC mutation negative tumors, there was a genome-wide hypermethylation with focal hypermethylation, which is exactly the opposite to the APC mutation positive, which was mostly genome-wide hypomethylation and focal hypermethylation, which is what we're more used to. We went back also, in this case, to the TCGA, and we did cluster analysis of the 200 most variable DMRs in the TCGA, and that yielded very similar results. So we really wanted to understand a little bit better the effect of these epigenetic changes in the regulatory regions. And what we did here is we annotated differentially methylated regions through this reference epigenome mapping consortium chromatin state map. And basically on their on the left side panel, panel A, you see methylation in APC mutation positive colorectal cancers relative to normal. As you can see, the big bar here is the hypomethylation, as we were talking about with these clusters of hypermethylation. When we look at panel B, that's the one where that's taking methylation in APC negative tumors relative to APC mutation tumors. And as you can see here, there's a very significant clusters of regulatory regions that are hypermethylated versus a smaller group of hypomethylated regions. So looking specifically at some of the genes that were affected for this, by this methylation, we saw that, for instance, there were 3 of the TCGA identified cancer driver genes, the SOX9, GPC6, and KIA1804, that were hypermethylated in APC negative tumors, whereas the same sites were hypomethylated in APC positive tumors. And we saw promoter hypermethylation in APC negative tumors that was observed in key Wnt signaling pathway genes that included GATA6, TET1, FAT1, GLIS1, for instance. So in summary, we see a younger age of onset colorectal cancer associated with APC mutation negative tumors. These tumors seem to show fewer somatic mutations and copy number alterations with an increased level of overall hypermethylation than APC positive tumors. The APC negative tumors are associated with a novel DNA methylation signature that's characterized by hypermethylation of select regulatory regions affected in particular genes in the Wnt signaling pathway. So the results of the APC negative colorectal cancer seems to point to a non-canonical carcinogenic process that is more dominated by epigenetic changes, less dominated by somatic mutational changes, and occurring at earlier ages. So the development of early onset colorectal cancer may often occur in an accelerated time frame prompted by environmental factors that impinge on epigenetic mechanisms. And that's what we are set to try to answer in the near future. So I want to thank, number one, the entire group of the Chicago Colorectal Cancer Consortium with a number of outstanding individuals who contributed to all the recruitment of all these patients and all the data and information. And this outstanding group of individuals, one of them sitting here, Rosa, and faculty here, and our collaborators in Arizona and University of Southern California, who really contributed in a determinant way to the success of some of the data that I just showed you. Thank you very much.